Welcome to Healthbeat, where we check the pulse of South Africa's healthcare system. I'm Mia Malan. As we mark World AIDS Day, the epidemic turns 44, and the hope that science could end HIV has never been more real. While new medicines to stop HIV offer hope for an end to the epidemic, US funding cuts have forced services to close, and support is out of reach for many with the virus. These are people who should be growing old on treatment that keeps them well, like retired Judge Edwin Cameron, who has lived with the HIV story from the start.
After I came out as a gay man in the 1980s, I became infected with HIV.
As a young judge helping to dismantle apartheid, he was also deciding whether to take the then new antiretroviral drugs. He contracted HIV in 1985 and stayed silent for 12 years.
This disease is the most stigmatized disease in human history.
By 1997, his health had collapsed.
I was going to be dead. The mean survival time is 30 months, 2.5 years. I should have been dead in June 2000.
Treatment saved his life and pushed him to speak out.
After a woman in Umlazi township called Gugu Dlamini died, I determined to speak out about discrimination and stigma and about treatment.
Cameron revealed his status, first to colleagues, then to the country, during his interview to be a constitutional court judge. In 2013 came another lifeline, a 3-in-1 pill that allows people with HIV to live as long as those who don't have the virus.
I'm very grateful for that, ladies and gentlemen. I wake up every morning thinking what an extraordinary thing it is to be a conscious human being.
When you came out as a gay man, if you had to compare that with coming out as someone living with HIV, were the responses different?
Yes. I came out as a gay man at the start of my legal practice in 1982. And at that time in South Africa, the criminal law, there were still raids on gay clubs, people arrested and charged right into the late 1980s. It was very different with coming out as having HIV and having AIDS, which I had both of them, because it's difficult if you affirm your queerness. It's a joyful thing, but to affirm that you're living with HIV is more complex. Gay men like myself in their early 30s, professional with their lives and their hopes and dreams before them, were dying in their tens of thousands in the western east coast of America, in the Midwest, Western Europe, Australasia, but there was nothing that could be done. So you faced a certain death, undoubtedly. I would not ever be 40. I was 33 when I was told, 32 when I was infected. I would never see 40 with certainty. I would never see a democratic, free South Africa. I would never myself become a judge, which I hope to do in a democratic South Africa. Worse was the internal shame I felt, and that's why I speak about internalized stigma, because I blamed myself. I believed that, I shouldn't have had so much sex, or sex with X or Y or Z. So there's a level of self-blame that is terribly debilitating. What changed it for me was meeting other people, and the other people I met weren't gay white men like myself. They were the spouses of mine workers who came to me when we'd started doing HIV work at the Center for Applied Legal Studies at WITS. And I was working with the unions. We were drafting AIDS codes, because by then it was becoming clear that we would have a mass epidemic in South Africa. Some of them told me that they'd never had sex with anyone apart from their husbands, and yet they felt the same shame that I did.
One of the biggest contributors to you speaking out was because you could now live. You were on antiretroviral treatment. But what we have learned is that people with HIV who started treatment at a later stage, so if you lived with a virus for a few years before being on treatment, that you're so much more likely to, for instance, have a non-communicable disease like diabetes or a heart condition. What is your experience?
I lead a healthy lifestyle, and yet I had blockages in my cardiac arteries, and I've got 3 stents in. I'm enormously grateful that I have access to the quality of medical care that is keeping me healthy. But all of that to say, Mia, that I have a sense of vulnerability. I exercise, I eat well, I'm mindful of keeping healthy, and of course, sustaining my adherence to my ARVs above 99%. If you're diagnosed with HIV and you are listening to us or watching us now, please start. And it's cheap. If you don't want to go to a government clinic, you can get your doctor to prescribe it. The ARVs I'm taking now, a Cryptiga, are costing my medical cover 222 Rand a month.
Edwin, another risk is mental health issues. How do you deal with that?
I deal with it through overactivity. I do too many things. I retired 6 years ago in August 2019 from the Constitutional Court and accepted a job as Inspecting Judge of Prisons, which has been enormously worthwhile and enormously instructive to me, but it's been a tough job. It's kept me busy with grueling work. And I do many other things in the public sphere, talking and lecturing and seminars and interviews like this one, which I've been very keen to do because it's the first time that I've been asked about aging and HIV. So I deal with those internal issues by doing too much. And it's a functional defense against depression, but you have to recognize that.
HIV has shaped people like you. It shaped your life because such a big part of it was fighting for access to medication for everyone.
I would say that it's made me deeply conscious in a life and death sense of how important social activism is, and civic action, and popular organization. Our institutions of government and our instruments of government are important, but they have to be shaped and pressured and demanded upon by civil society action.
We started with public rollout of ARVs in 2004. We've made so much progress, and we've had buy-in from wealthier governments to help us and other African countries. And then 2 decades later came 2025, and it all almost changed overnight.
The Trump-Musk interruption of the rollout has been severe. Musk informed the aid agencies, USAID and the other grantors, that they were cut off, that they were going to be left stranded, and that all their beneficiaries across Africa and elsewhere were going to be left stranded. It created an immediate emergency, and it appears to me that government did not react in accordance with that sense of urgency, that sense of crisis.
If you were the health minister, what would you have done?
I would have jumped into action. Immediately, I would have pressed the finance minister, Godongwana, for help to cover the 8 billion rands, which we were receiving in PEPFAR and USAID funding. I would have pressed to get to the front of the queue to ensure that that money was made available.
And now we do have a bit of hope. There is the twice yearly anti-HIV injection that we've registered in South Africa, lenacapavir, and our health department does want to roll it out and is rather committed to do it. But again, we face inequality.
It's not just income, because in a properly functioning society, you'd have far more widespread access to healthcare, and we should be doing that. But it's also agency. If you are in a rural area or you are in a very resource-deprived township, you don't live in a circle where people can simply say, oh, well, make an appointment with your doctor tomorrow morning. pick up your iPhone and speak to the receptionist and get an appointment with yourself. It's much more difficult. So inequality at almost every level of healthcare access impedes the poor and enables the more affluent.
Thanks very much for your time today, Edwin.
What a pleasure. Thank you.
Welcome back, you with Healthbeat. Masiphumelele is a community south of Cape Town of about 30,000 people. Here, about 1 in 4 adults have HIV. The new infection rate among teen girls and young women is particularly high. For over a decade, the community of Masi and scientists at the Desmond Tutu Health Foundation have worked towards stopping HIV in its tracks. Catherine, thanks for inviting us to the site today. What happens here?
You're absolutely welcome to be here. So we are a clinical trial research site. We've been here for 20 years conducting HIV prevention research.
Scientists have made it as attractive as possible for the young people of Masi. There's a gym and safe spaces to hang out, while involving them in the Purpose 1 trial, in which over 2,000 women received the lenacapavir injection. Thousands more received a daily pill, which also prevents HIV infections. The study tested which worked better, the lenacapavir jab or the pill. Catherine, you were one of the chief researchers in the Purpose 1 trial that found Len to be 100% effective among young women. How did that work?
It was honestly the highlight of my career, super exciting. And the reason why it was so exciting is not only was it 100% effective, it was the first time adolescent girls were ever included in a trial like this, and also the first time that pregnant women were included in a trial. And for me, that is such an advance in the way that we do trials, because now that we've shown that the drug works, those groups don't have to wait, and they are the groups that are the highest risk.
That's why, after 3 years of using the Len injection as part of the study, Buhle Sekadi is still coming back for her shots every 6 months.
My name is Buhle, 22-year-old. I live in Masi, grew up in Eastern Cape, had to come this side because of looking for a job and also looking for better opportunities.
Did you use the pill before you went on to Len?
Yes, I did. It was a very difficult one because once you forget to take them for more than 2 days or 3 days, then you have to start all over again.
So you've had 6 injections because you take it every 6 months, right? And you've done so for 3 years because you were part of a trial that tested if it works. Why have you decided to continue?
You know, in the world that we live in now, we don't feel protected. There is high rate of rape. So it's not more about having sex. So I decided to protect myself, because I may never know when my luck will run out and something bad may happen to me and then I get to be infected with HIV.
Have you experienced any side effects?
There were no side effects besides the lumps.
So are there little nodules on your skin where they lifted up your skin and put the injection in?
Yes.
And after how long did they go away?
For like a month, they fade away like completely. So it's high time that the youth, even the people, the ladies, the men, decide that to take the choice and save themselves and protect themselves.
How long do you still plan to take it?
Until I die.
The research team has since launched a new study, now testing a longer-acting version of the HIV prevention pill. You are testing a monthly pill at the moment that can prevent HIV infection. Yes. Why is that? We have a daily pill at the moment in South Africa. Why do we want a monthly one?
What we know from contraception, which has been around for a long time, is that the more choice that you give to people, the more likely they are to use the product. So we have an oral pill, we have an injectable, a 6-month injection, and what we're hoping with the monthly pill is that that will offer people choice. Our work with these young people is really to try and find products that fit into their lives.
This is what hope looks like in 2025. Young women making their own choices about their bodies and their futures. After the break.
Miraculous. It's 6 months. This is extraordinary to have something that lasts that long.
You're back with Healthbeat. In the early 2000s, activists fought for access to HIV treatment. Now the focus is on medicines that can stop infections before they start. Linda Gale Becker heads up the Desmond Tutu Health Foundation. She led the trials that proved lenacapavir to be 100% effective among young women. And now she'll see it rolled out in South Africa. You have worked in HIV prevention for a very long time, and you and other scientists are so excited about lenacapavir. What makes it different?
One of the most intractable problems has been reducing new HIV infections in young people at large, but in particular young adolescent girls and women. We had about 160,000 infections in the country last year. That works out at around 400 new infections every single day. And of that, 1/4 are young women and girls, so about 110.
Why is it young women and girls?
We live in quite a patriarchal society where it may not be possible to insist on condom use. Of course, people may not be employed and therefore, from a financial point of view, are dependent on older partners. And then there are biological reasons. The virus accesses young women via the genital tract more easily because young women are not yet mature. The mucosa could be a lot more penetrable. If sex is rough, the virus more easily again gets through the mucosal surface. We think it is multiple reasons. It's not that young women are having far more sex than everybody else.
So what is it that lenacapavir can do for these young women better than a daily pill that we've had for over a decade in South Africa?
So I think the first thing to recognize is pre-exposure prophylaxis really protects this young person from HIV, should they be exposed to HIV. So it is discreet, it's user-driven. I can do it for myself, unlike a male latex condom where I have to request a partner to use that. So this gives this person autonomy and it's very much in their own hands. The problem with oral PrEP is it's 2 antiretroviral agents brought together in combination as a single pill, which has to be taken daily ahead of the risk of HIV exposure. Many reasons why young people say taking a pill a day is difficult for me. They start well, but it falls off over time. And if the pill and the drug is not on board at the right level in the bloodstream, it cannot work. So enter long-acting, less frequently dosed interventions, 2 reasonable injections that can be injected once every 6 months, and you change that narrative completely. And that's exactly what lenacapavir has done.
So South Africa is going to start to roll out lenacapavir with some donations from the Global Fund in April next year. Can you explain to me, if I go to a clinic and I think I need lenacapavir, what happens?
So it's going to depend a little bit about where those 500,000 doses are going to be put by the National Department of Health. My hope is that they're going to put it in the regions where HIV burden is greatest, and it'll be in the clinics. And when somebody walks into the clinic and they feel that PrEP would be beneficial to them, they will be offered the choice of oral PrEP or injectable lenacapavir. So 2 injections either side of the belly button. The same time, there are 2 pills that need to be taken on the day that you get your injections, and you will take 2 pills home, and tomorrow you need to remember to take 2 more pills. And then you are good to go for the next 26 to 28 weeks. miraculous. It's 6 months. This is extraordinary to have something that lasts that long, but it will run out. And that's the important thing. You need to come back for your top-up injection because it will run out. In the same way, you need to take your pill, if it's oral PrEP, every day because it runs out. When it comes to PrEP, you have to have an HIV-negative test. That is very, very important. Nobody should use lenacapavir or oral PrEP if they are living with the virus already.
And soon you will start to roll out an implementation trial.
We don't know how well or how easily lenacapavir is going to fit into our health system, how well healthcare providers will deal with it, and indeed whether the public are going to want it, use it, find it acceptable. All of that still needs to be established. We hope that, by offering choice, fitting in with people's preference, trying to make it as amenable to people's lifestyle as possible, we will have a much better uptake of HIV prevention and we'll begin to see HIV go away in this country.
And will you offer it to anyone, or do you have specific populations that you're offering it to?
In our implementation science project, we are honing in on people who are having the most sex, we believe, and so we're going for the younger population. So this will be people between the ages of 16 and 29. We are honing in on adolescent girls, young women.
Now, how long does a young person need to stay on HIV prevention medication?
Unlike antiretroviral treatment for HIV, we don't imagine this as lifelong. If I can use the analogy, because I think people will understand this, of contraception. Women know that they need their family planning at the times when they're most likely to be getting pregnant, and that's when they're planning their families accordingly. Similarly, we think people will figure out that they need PrEP at the times when they're most likely going to be potentially exposed to HIV via sex.
How many people need to take HIV prevention medication to prevent one infection?
You have to overtreat with prevention because you don't know who that one person is. You can't predict it. In order to avert or stop 250,000 infections, we have to give this to more than 20 million people. So just to get people's heads around how vast prevention is going to have to be. And that's why it's got to be dirt cheap and it's got to be very easy to give. And that's why I'm delighted that we've seen the price come down in the generic form. And if we don't do this urgently, boldly, this epidemic will continue and cost more lives, cost more South African rand into the future. Now is the time to turn this around.
Linda Gelbecker, thanks very much for your time as always.
Thanks, Mia. Happy to be here.
That's it for HealthBeat for this year. Have a healthy and a restful December. You can contact us at health@bekesisa.org. Thanks for watching.